It's nice to be on the other side of things. I say that every time I do CPC for chief resident, and I just had told Dr. Cheng it's just as hard to give it as it is to do it. It just takes an awful lot of time. The case that we'll be presenting today is a real live person, thankfully, and somebody who was on my inpatient team in July last year with Malik. It was a bit of a challenge for us, and I will be the first to admit that I have simplified a few things. So basically, I've lied in a couple of situations. So you all probably already know this, but this is a 23-year-old woman with a prior history really only of generalized anxiety disorder who presented with several months of persistent cough, chest pain, and 6 weeks of fever and dyspnea. And today, your very own chief resident, Edward Daniel, will be the discussant. We're so glad to have him. And meet our expert.
Quote unquote expert. I'm going to steal the clicker here just to go through the stuff. Hi guys, you know me. I'm Edward. That's me. That's my official picture. Bright-eyed, bushy-tailed, early as a chief. Don't know where that smile went. I'm joking. It's been great, guys. It's been great. We'll have jokes for you throughout the rest of it. Does this work? There we go. So yeah, I'm a chief resident with you guys. Went to Harvard and UT Southwestern for med school and grad school. Got both MD, PhD. Obviously, I'm here for residency. Next year, I'll be a hospitalist, so I'll still be #here with us. Let's hop into the case itself. So I want to thank Dr. Defer for giving me a really juicy one-liner. There's a lot to dissect from this. When I got this, I was like, oh, all right, let's hop in. So I'm going to work on this backwards to forwards. So I'm going to first look at the symptoms here. We have persistent cough and chest pain, fever, and dyspnea. And the thing that I really find very helpful here is actually this fever. Because when someone has a fever, a true fever, that suggests an underlying inflammatory state. The inflammatory state could be all kinds of things. Typically, we think of infection. But other things include malignancies, autoimmune disease. In fact, I'm just going to go ahead and skip to this next slide. I stole this from Clinical Problem Solvers. We are lucky to have 2 people of the Academy who are residents here, that being Noah and Dr. Noah. Oh my God, I'm blanking on his last name. Noah and Marcella. Yeah, I was just trying to. Yeah, okay, sorry guys. Anyways, so Noah and Marcella, they're very involved with this. We had a chance to present a case to CPC and to Robbie, and it was a really fantastic experience. We can see here, they have this nice mnemonic I made: infection, malignancy, autoimmune, drug, and endocrine. And when we think of fever initially, it's like, okay, infection is really the first thing we think of. But what really helps stratify this is actually the time course. So early on, if someone has a fever, we're thinking infection, infection, infection. But once that fever starts lasting for longer periods of time, that's when we start considering these other options down here on days to weeks: malignancies, autoimmune, drugs, all that fun stuff. Not saying that infection is not a possible cause, but the chance that this is like a bacterial and a standard staph bacterial infection or something like that is lower on my concern at this point. The infections that we see up here would be things that are more indolent, things like tuberculosis, things like syphilis, complications of HIV that could HIV itself, and complications of HIV, I should say. Difficult to treat diseases that are in hard to treat areas like osteomyelitis, endocarditis, those things. And so what helps us further with this is the time course. So several months and 6 weeks. So we just go ahead back to this. I'll talk about the other symptoms in just a second too. We were really kind of honing in here. So something here is probably where this disease is. There's some kind of malignancy that's happening, which unfortunately certain malignancies are becoming more and more common in younger patients. Autoimmune disease, she's a 23-year-old female that's like the ripe demographic to have some kind of autoimmune disease. You can see some examples there: lupus, Still's, vasculitis. Crystal disease is probably not the case in this situation. She does not fit that picture very well. So likewise, I'm probably not suspected for myositis. I suspect he probably gave you something a bit more than that, but we never know how much we can get with these one-liners. Drugs we'll talk about, and of course, endocrine as well. Again, we're not excluding the possibility of infection, and we have to do a proper treatment for this. Some people may say this is a fever of unknown origin. I want to clarify that fever of unknown origin is 3 weeks long after a week of appropriate treatment, appropriate evaluation. So she has not had appropriate evaluation. We can't say this is fever of unknown origin yet. I'm going to go back one slide here. The cough, the chest pain, the dyspnea. Obviously, we can talk a lot about what can cause cough, what can cause chest pain, what cause dyspnea. This is bread and butter of what we do in medicine. What I'm going to take away from this is that these are all symptoms that localize to the chest in some way. Lungs, cardiac, other things are related with that. And so I'm saying, okay, there's some kind of inflammatory state that's localizing to the thorax in some kind. And that's kind of where I'm going to be targeting. We're listening to more information about it, as well as targeting initial evaluation is intrathoracic pathologies. And then, okay, now the other thing here, there we go. So the thing that can help better stratify this is actually her age. So I mentioned 23-year-old woman, ripe demographic for having an autoimmune condition. Also, what about malignancies? When we think malignancies, the ones I think about are probably more the hematologic malignancies, lymphomas, leukemias, that'll be a bit more prevalent. Probably, but at the same time, we're seeing all kinds of more solid tumor cancers. Unfortunately, I have friends who have developed metastatic colon cancer, a few years older than that. So doing appropriate consideration, has she been losing weight? Are there any other symptoms that can localize this to a specific possible etiology of like a gastric cancer? Do they have any kind of lymph nodes anywhere that you notice on palpation? Things like that. And then lastly, the generalized anxiety disorder. There's a couple things I take away from this. I actually put these question marks, so I'm not too sure exactly how much it will help with the case. But two things I take away from this. One is that if she has this diagnosis, that means she has had some contact with healthcare. So maybe she has some labs. We can have at least a baseline if there are any changes in labs. Other thing too is what kind of medications does she take? So she may be on medication for that. And I don't really have much more other than say the generalized anxiety disorder. One last thing with the 23-year-old I forgot to mention too is the pretest probability of her having a chronic disease that we deal with, like diabetes, hypertension, HFrEF, things like that, are much lower. So to kind of illustrate the point of because she's 23 and those things usually take time to develop, if something were serious, I would think that Dr. Defer would be nice enough to give it in the prior history, but you never know exactly how these things work out. I do want to do one little fun end. I've been talking a lot already, and he's like, let's get on with it. So here's the one-liner. I want to do just two quick things and just see how much things change. If we just change one little thing here, instead of being several months and 6 weeks, we change it to 2 days. Everyone's like, this is some kind of respiratory infection. You get an RBP, you get a chest X-ray, any kind of infection, you're starting with antibiotics. If you see consolidation, this is infection. Just changing that one little detail drastically shifts everything back over to one side. And we change two little details, and this she's 53 years old, and just get rid of that fever. Now we're like persistent cough, chest pain, dyspnea. We're getting a chest X-ray, cross-sectional imaging, probably getting an echo. Is there lower extremity edema, looking for heart failure symptoms or signs of volume overload? Does she smoke? And is she smoking? Now she has COPD. But now you can see how just these little details here and there would drastically shift back and forth between the differential initially. But that's not the case. This is the case. So the way I'm going to target is, so first off, my problem representation initially is, like I said before, a young woman with chronic and progressively worsening inflammatory condition that is currently localizing to the thorax. And my target approach, the things I'm going to listen for and look for from the information that Dr. Defer will provide. So on HPI history, to be honest, he gave me a lot with that one-liner that like, you can give me more information about the chest pain, you can give me more information about the breathing issues, but what I care about is more about the review systems in this case. Are there other systems affected that would raise my concern for one of these processes? Does she also mention that her urine is changing color and it's like, okay, this is more of a vasculitis thing? Does she have a rash on her body? Again, something kind of autoimmune. Does she mention weight loss, palpitations, things like that? I mean, maybe it's hyperthyroidism. We're just throwing ideas out there, but how the review systems will start shaping my way to one of those big buckets. Similarly, medication, any substance use history, we want to make sure you do a good review of that. And then social history. Like I said, don't forget the infections, those weird infections. If there's any hint that there's a weird infection, she traveled to an endemic country where tuberculosis is more prevalent, or she got, or malaria, for example, like all those things. The second, I know you guys who go to my report, the second we have any kind of travel history, we're like, ooh, what's happening here now? So make sure you have a good social history, any kind of possible exposures to evaluate for those weird infections. On exam, we're going to do a lung auscultation, a thorough skin exam for the same reasons kind of up here above. And then anything else you figure out HPI, I want to be targeted for that. Objective studies, the CBC. Actually, the CBC is really helpful. If the blood counts are low, hemoglobin's low, what's the cause of the anemia? Is it microcytic? Is that anemia of chronic inflammation or some other cause of anemia? Is there neutropenia as well, or leukopenia? Is there decreased platelets, just pancytopenia? All these can suggest some degree of chronic suppression. Or is the white count 100? Well, we have a blood malignancy at that point. We got to get a bone marrow biopsy. So a lot of information can be gained just by looking at the CBC and how those different cell lines are affected. I didn't mention, I forgot, I was thinking about this a bit more. It's not because Dr. Chang's right there, but I also want to see a creatinine. A signs of any, yeah, there it is. He's very happy about that. See creatinine, very low threshold for UA because a lot of those diseases we talked about affect the kidneys usually in one way or another. If there's no real sign of kidney disease, I'm like, okay, cool, we can check that part off, move on to the next thing. She's going to get cross-sectional imaging of the chest, almost certainly. You're going to start with a chest x-ray, but the cross-sectional imaging. The one thing I'm going back and forth on whether we want the high-resolution CT or just a normal chest CT without contrast, probably a normal to start off the case, because my suspicion, because this could really be anything of those buckets. The high-resolution CT would be useful if we're really concerned about autoimmune, and that will come up as we get more information if that's the case. And of course, can't miss things. Cardiac issues, the serious infections. I already mentioned kind of the serious infections. So she's going to get the blood cultures, the respiratory virus panel, all the usual stuff that we do. Going back and forth on whether, get a troponin, get an EKG for this chest pain, unless it's such obviously that's GERD or not cardiac, and fine. But given the situation, the fact that this is CBC, she's probably going to get that. Probably get an echo, again, looking for endocarditis. And that's kind of, I think, sufficient workup for cardiology initially, pending future information. And then I'll probably go ahead and send off the whole gamut, HIV, get a T-spot, get an RPR, all that fun stuff. So I am all done talking. I thought it was going to take about 10 minutes, so I'll hand it back over to you, Dr. Fur.
Okay. Just to warn you, we're going to go through this at pretty breakneck speed because a fair amount of things actually happened, and I have left some things out. But if you ask about them, I'm prepared to fill them in quickly.
Great.
So my hot take is called running point. If you love Ted Lasso and don't mind dysfunction, you will love Running Point. I consumed it all in one evening. I liked it so much. Is it as good as Ted Lasso? No, it is not. But is the message the same? Do what's right and fundamentally things will work out? Yeah, it's the same message. And that is not Jason Sudeikis, but pretty great show. I'd be shocked if it doesn't come up for a second season. So here we go with the actual history of the present illness. 23-year-old woman, very minimal past medical history, generalized anxiety, and allergic rhinitis. She presents with several months of cough associated with chest pain. 6 months before the admission, after returning from a trip, she developed intermittent low-grade fever, and during that time, the highest that it was 100.5. And she had a notable increase in her cough after getting back. The cough was now occasionally productive of clear sputum, and every once in a while there would be red specks in it, and sometimes it would be pink. She began to experience fatigue and dyspnea on exertion as well. About 5 weeks before, she had a chest x-ray. So yes, she did have some contact with her primary care provider, and it demonstrated a focal right upper lobe opacity about 3 inches in diameter. I don't think anyone was expecting that that's what it would show. She also had a CT scan, and this is the reading. Bilateral upper lobe opacities with ground glass attenuation surrounding, compatible with pneumonia. There were some areas that might have suggested cavitation. She had a bronchoscopy done 2 weeks later. Not sure why this took so long, and she was not treated in between. So she had a bronchoscopy, and it was quite difficult. Her airways were small, she desaturated, she had to spend the night in the hospital. That did BAL, brushings, biopsies were all done, and all the cultures were negative, and they included bacterial, AFB, and fungal. And the biopsy that was obtained from the trachea simply showed chronic and granulomatous inflammation. As an important point, I think, her histoplasma antigen was negative. Finally, she was treated for 7 days with ceftonir and linezolid. Why, I don't know. I don't make the rules, but she was treated.
I thought too.
And she did not improve. Her cough and dyspnea on exertion increased. And by the time she got to us, she was having fevers in earnest. She had lost 12 pounds and she was feeling very unwell and very anxious. She literally, you could see her trembling from anxiety. Reminder, she's only 23, no prior medical issues. So, past medical history is, as I have told you, only other thing constipation. All of her family as well. She has no allergies. She's on expected medications, bupropion. By my estimation, it was not working. She's single, a computer engineer. She has a dog and a cat at home, never smoked, no passive exposure, no vaping, modest alcohol, never used illicit drugs, and had not had any recent sexual activity. Here's that review of systems. You know, it's mostly the things that we already have. We know about the fever, etc. She did mention some night sweats, and she did mention intermittent nasal congestion, which at the beginning of the illness was thought to be the problem. So at the beginning, when we said she had some cough, she was treated for allergic rhinitis with no particular improvement whatsoever. That is your first foray of information, and it's a lot.
Yeah, thank you very much. So can we go back to that first slide? So things that are new have come out is really the big thing that I'm looking at is hemoptysis. So specks of blood with sometimes pink. And when we think of hemoptysis, you're definitely more concerned for a variety of things, infections, any kind of inflammation. Again, my comment before from inflammation to the thorax is what I'm is initially, and this is suggesting that more and more. Is the hemoptysis due to maybe some of an upper airway thing, that there's trauma from this cough that she had before, just coughing so much she's coughing it up? Or is there actually damage to deeper vessels? Is this, again, due to some kind of weird infection happening on? Is it an autoimmune dysfunction? Is there a malignancy? She actually have a really bad hematologic malignancy that's leading to defects in coagulation, or is there another reason why she is unable to properly coagulate and that therefore she's bleeding around in her lungs? The other thing that's new is really the allergic rhinitis. I guess if that's a chronic thing, get some Flonase. So a lot of patients with allergic rhinitis, not too sure what to make of that. You did mention the congestion a bit more too. We'll see if that has a role or not. I'm kind of keeping that back in my mind, especially if she has now hemoptysis. Again, the autoimmune thing, if she has nasal, I'm just blanking on words, guys. I'm so sorry. Sinus, that's the word I'm thinking of. Sinus issues along with lungs. Then she, is this kind of one of the vasculitis? I don't know. Again, the incidence of those things are so common. My daughter has had congestion since October. I don't think she has an autoimmune condition or vasculitis. Depends on the time. You said this is July, so this is probably from January through the few months. So unclear exactly, obviously lots of pollen there, how that would play. What's the next slide? Oh, where did she go?
I can tell you that in a moment. How about that?
All right.
What's your thoughts
the travel
here?
history. I saw the travel.
I
I was looking out, usually go, ooh, travel, where'd she go?
Where'd she go?
Again, those not as typical infections would be, similar to keep in mind depending on where she went. They actually has a good amount of workup done. The chest X-ray, and we see a focal right upper lobe opacity with these symptoms and hemoptysis. I think every ID doctor is like, for the love of God, please test to check a TB, because that sounds like concerning. Of course, there's somewhere down there it said there was a cavitation intrapulmonary abscess. So hopefully she got AFB cultures. I don't know what the exact sensitivity of those were done from a bronchoscopy, but at least other studies to evaluate for TB. I guess probably should be pretty good.
And those were washings.
Okay.
And the washing went poorly. Very limited return.
I'm not too sure what to take away from that issue. I'll go ahead and say that I don't see any pulmonologists here to help chime in on the quality of whether return or not is helpful with a bronchoscopy. The chest CT then gives a surrounding ground glass attenuation, most compatible with pneumonia. Ground glass is a very non-specific finding. It can be found, like I said, with pneumonia. It can be found really kind of any reason to have increased I believe it's edema in the chest. You can get that ground glass opacifications. And then the signs of early cavitation, intrapulmonary abscess, combined with this granulomatous inflammation. Granulomatous inflammation could be something like sarcoid. Again, TB. Again, please, let's do all the TB stuff because TB can present as anything. And I had a friend in college who developed active TB. Granted, he was from Romania, so that's why the case. So evaluating for that, but of course, autoimmune disease. So at this next slide, sorry, let's go through everything. Yeah, I agree. I don't know what the ceftiorine linazolid was for. It's a way to treat. It's antibiotics that could treat pneumonia, but given the fact that she did not improve with that, it would argue as everything else. If this was CAP, then that would be a very boring CPC. And then obviously worsening of her disease. Now true fevers, losing weight, feeling very unwell and anxious. I think next slide is the just keep all that in mind. I'm going to summarize stuff in a little bit. In her patient details here, it's actually pretty much unremarkable. She's a little bit of constipation. I think, and the reason that's good is it checks certain things off, things that I'm less concerned about. So in terms of medications, bupropion, psyllium, nothing too crazy with that. Her social history seems very tame. So the risk of her having HIV is lower, my concern, or having some kind of sexually transmitted disease or infection, is a little bit lower. We'll figure out where the travel history has gone. Because it's lower does not mean we're not going to test for it. But now I'm like, okay, maybe a little bit less on HIV, a little bit less how would she get endocarditis unless she has some kind of instrumentation in her mouth or something? But I suspect that will probably pop up somewhere in the history. How would she have developed osteo unless she had a risk factor for that? So those weird infections go a bit lower, with the exception of things like histo, you mentioned was negative, any kind of inhaled intrapulmonary infection like histo, like the other endemic mycoses, the non-endemic mycoses. If she traveled up to the Northeast and someone got bit by a tick, got Lyme, somehow it'd be a very strange presentation for Lyme. But those kind of weird things that are not go through those vectors. And then lastly, for the review systems, I think the thing that pops up here is her weight loss. Looking more towards malignancy as a cause is a big thing for weight loss. We should always evaluate for that. I'm curious if that weight loss is primary because of the disease. If she's at this increased inflammatory state, her body just revved up because of what's going on and trying to fix it. Is it because she's just been feeling crappy and just doesn't want to eat? Those are all possible reasons for weight loss. But when we see fatigue, fever, weight loss, occasional night sweats, those are B symptoms. So we need a proper evaluation, make sure she doesn't have a brewing lymphoma. Presumably, the CT chest would show something like that. But if the lymphoma is in her abdomen, initially to start, then it would not be picked up on the CT chest. Again, the blood specs, the hemoptysis is she would need a little bit further evaluation if she can get another bronch or something. That a bit better. Was that bronch done? It doesn't matter.
Outside hospital.
Okay, but getting the bronch with a little bit better evaluation would be pretty helpful. I don't know what to make of the constipation and the anxiety. I mean, we know about the anxiety. That's her history. I don't know what to make of the constipation. I think that's sometimes people have these issues. I'm not going to look too much for that unless as we get further workup, there's more GI issues, and then we can evaluate that, talk with our friends in GI, and get them involved to help out. So cool. So again, at this point, the big salient things, aside, in addition to the one-liner, because those are a lot of really helpful things there, is the signs of hemoptysis and the weight loss and night sweats, all suggesting, again, this is a truly inflammatory process that is really something probably more in the lungs and the heart. So we have that degree of focus. Is there something with upper airways? Possibly. Is it lower airways? We'll figure it out. And I think that's all we got. So next we get some basic labs.
I'm going to give you that additional history.
Oh, okay, fun. Even more history.
She was beaten to death with questions about her travel history.
Cozumel.
So to demystify this, she had gone with friends on a trip around the United States to visit national parks. And most of the time it was camping. And these are all the states that she went to. She went with her parents to Cozumel in 2023, so pretty remote. And she did visit a few. We never could, was it 2 or 3? but she did visit a few caves as part of tours. She's not a spelunker where she was going by herself, going into teeny tiny cracks and crevices. She denied any known exposure to bats, but it's a cave. And no other close animal contact, including birds, and no known tick bites. She has no exposures except to her computer at work.
Yeah. You know,
There you go.
not same. We have words.
All right, physical exam.
Well, before we go, just go back.
Your thing.
So this is like, an infectious disease. This is, I had a report recently where, classically infectious disease, like ask all the more interrogating questions and figured out the underlying cause of it. Dr. Chavez was there for that report, in fact. I mean, this opens her up. You got to all the stuff I said before, endemic mycoses are really high up there. And then really the Cozumel, Mexico, I don't know the exact, if it's just like to the report or the resorts or something like that.
It was a resort.
It was a resort. That's helpful. I mean, there's no way she's escaping a tuberculosis test. As well as all the other tests. Like this is very, very interesting. But like, again, this just further supports the idea that we should test for all those things. It doesn't actually, like, I was going to test for them regardless of all this, just to make sure. This is like, yeah, we should definitely 100% test, make sure you get all the appropriate urine. We got the urine histo, but blasto, cocci, probably crypto, if we're even concerned about that. I'm trying to remember from Dr. Roseo's new conference on Monday, all the stuff to test. And of course, tuberculosis as well as all that.
There's a lot of OCs to worry about.
Lots of OCs.
Now, the physical exam is disappointing. She's a thin woman who appears anxious and ill, kind of flushed in the skin, given her fever. She's tachycardic, and I ain't got nothing else for you.
What helpful thing is the skin. I mentioned looking at the skin from before. Skin is a common area for various autoimmune disease. So the absence of rashes kind of lowers my concern for something like lupus, for a myositis. This is not really a myositis picture. She doesn't mention any kind of weakness in muscles or anything like that. But lupus can certainly present in this way. Of course, there are plenty of other autoimmune diseases that do not have any rashes with it. Sarcoid, the ANCA-associated, the vasculitis in general, I should say, not just ANCA-associated, but like, given what's happening, it's definitely high on my differential. And that's all I really got. So
yeah, sorry to disappoint you there.
Sorry, I'm used to it.
Okay, your initial labs are these.
Cool. All right. So going through her
I've
labs.
conveniently marked the abnormal ones for
Thank you. Creatinine's technically not abnormal given her BMI, but it's not high. So there's no overt signs of kidney injury. We'll get to that urine UA in just a second, Dr. Chang. The chloride's a little bit low, calcium's a little bit low. I think it's really, the calcium is related to the albumin. Looking at the albumin, trying to figure out why that's a little bit low. It's, I'm not sure. And then the alk phos is elevated, AST is elevated, AC over ALT greater than 2 to 1. Does she actually drink a bit more than she's letting on? Maybe. There may be some signs of maybe some damage to the liver. I'm trying to kind of piece together why this hypoalbuminemia. But now that I look at it, I actually can do proper math. She has a pretty decent protein gap. It looks like 4.4. So that's an elevated protein gap. Again, is that due to is that because of polyproteinemia from an autoimmune condition or other reason? We would probably get an SPEP to evaluate for that. And at least a spot UPEP. Though in the UA, transitioning there's trace protein. Again, there's limitations of interpreting a trace, interpreting that in the protein, that in the UA, but there's blood. So there's white cells and red cells greater than 5. And that does suggest some degree of inflammation in the kidneys itself. So the creatinine is normal, but there's some signs of inflammation. This is why nephrologists love their UA. Also costs like a few cents. Like it's insane amount of information we get from. It's like the true high value care is looking at that. So now we're concerned. Okay, we have inflammation in the lungs. We have signs of inflammation in the kidneys. Are there any other organs affected? Maybe the liver with the alk phos elevation. Maybe getting a GGT to make sure it's due to the liver, or is this more of a bone issue? And then lastly, going to her white count, she has a pretty decently microcytic anemia. somewhat decently. Does she have baseline iron deficiency anemia? I feel like that's decently common in our patients who menstruate. I feel like there are several patients we see in the clinic who have those issues. So we would want to do appropriate workup for that, though this could also be very consistent with the inflammatory state that I mentioned before. Likewise, the elevated white count, the elevated platelets counts are reactive. It's not something that's screaming now that it's a leukemic disorder, or at least an acute leukemic disorder. We have not ruled out a lymphomic disorder. I don't know if that's lymphomic is even a word, but we're going to make it a word now. All right. And lymphoma, we have not ruled that out. You can have a pretty normal CBC with a lymphoma, but definitely shows that there's a little bit of inflammation that the body's responding to with the elevated white count, likewise with the platelets. It does say that the bone marrow is probably not that suppressed. If we can make that much white cells and platelets, it may not be located to the bone marrow itself. And then not neutropenic, and at least she doesn't have an elevated INR, so she's at least no initial signs of coagulopathy going on with that. I wouldn't be surprised to check a PTT as well, but I suspect that was probably, hopefully that's normal, in which case we have to suddenly transition to a coagulopathy talk, which is not something I was expecting.
And you shouldn't worry about that. The INR did not change, and there was never a PTT done. Also, to put you a little bit out of your misery, the liver function tests or liver damage tests, however you want to think about it, never went anywhere and essentially normalized. She had 2 repeat UAs, which were essentially the same, and her hemoglobin for a time remained the same.
Okay.
So I think, for time's sake, I know that you want chest imaging, and you had specifically mentioned cross-sectional imaging, and I will give you that. We have Dr. Casey Kuykendall from radiology to lead us through the first chest X-ray that we did here and the first CT that we did here.
Seeing the majority of the lobe, we don't have that prior to compare to. There's also this contour abnormality of the right heart border, which can be seen in the setting of lymphadenopathy. Then additionally, there's peripheral consolidations, predominantly in the left upper lobe, but a little bit in the right lower lobe as well. On CT, these findings were confirmed. We see these upper lobe consolidations. It's more peripheral in the left upper lobe. And then there's additional peripheral consolidations in the lingula and right lower lobe as well. I did not see any abscesses that they were concerned about at the outside hospital. And then there's a few like borderline enlarged lymph nodes, but no mass-like conglomerate lymphadenopathy.
Okay.
Okay, so that's your first bout of imaging.
I think it's pretty consistent with what some before, at least kind of with the absence of abscesses. So it is helpful to see that the lymphadenopathy question mark is something we'll keep in mind. Again, the things I'm thinking about right now is, make sure we rule out the weird infectious. So probably we'll get the infectious, like I check out, make sure it's not HIV, all the, endemic mycoses, RPR, tuberculosis is probably the next step, because I want to because if it is that, then that entirely shifts us to treating for infection, and those tests come back quickly. Is also conveniently the next option there. So that's great. That's, so not Legionella, histo, well, everything's been negative. So at least that helps lower my concern for those things. I assume TB was in the extra one. I saw there's extra infectious workup too. So
there's 2 extra infectious workup.
All the infectious workup. Oh my goodness. Okay.
Yeah, there was a T spot done outside the hospital that was negative.
Great. Okay. So I'm glad to get to check again. We're checking those things off. My suspicion for those is low, now lower, previously low, now even lower. So anchoring now more on, is this a malignant process? Is this a autoimmune process? And I think the other thing, I guess just to check it off, the anemia workup, I just make sure that iron labs and ferritin. So ferritin's a little bit elevated. The iron's actually, the T-sat's pretty low. So this could be more of a mixed picture of what's going on. The haptoglobin and LDH are also elevated. The haptoglobin, I remember talking with Dr. Blinder, you only need a small amount of hemolysis to actually make the haptoglobin completely disappear. And so elevated haptoglobin LDH is probably more related to this increased inflammatory state than true hemolysis. So kind of a mixed picture so far with regards to the anemia of both anemia chronic inflammation, probably a little bit of iron deficiency as well. But that's kind of what I expected for the most part. Just again, checking things off.
And for those of you who are like, did you look at the smear? No, because there was never any abnormal morphology on the screen.
Sorry, I don't think we have any hematologists, maybe future hematologists, but no board certified hematologists. Maybe they are. Okay, so really at this point, the things that we would need to do workup is, again, the autoimmune disease is definitely still pretty high. We've done the initial workup for infectious stuff and say, okay, it's not the big stuff there. Now we can move on to the other things. We would want to get an ANA, get the ANCA panel. Probably just ANCA and ENA, I should say too. Like, do you get an RF? I don't know, probably not RF because I'm not concerned for rheumatoid arthritis. The rheumatoid arthritis can present with ILD. There was an ILD picture, though, that was discussed on that cross-sectional imaging. I was going to say, of course, ESR and CRP, though, those are going to be elevated. Like, we're going to get them, but they're going to be elevated. So really, it's the other autoimmune workup that'll be super helpful here. Told you, ESR, elevated. RF is elevated, okay.
Some things take a while, by the way.
Okay.
They go to our friends in the north.
Yes. Up at
Mayo Brothers Clinic.
Mayo Brothers, indeed. So the IgG, of course, thank you, compliments as well will be related to that. So lupus tends in a few other autoimmune conditions, but lupus predominantly is what I think of that can lead to hypocomplementemia, which she does not have. And so, the IgG levels are variously fine. IgM is a little bit low, but everything else is. So it's not some kind of weird immunodeficiency going on. A little bit surprised if, actually, no, I think that's pretty reasonable. Again, ESR is elevated. I don't see a CRP. RF is fairly nonspecific. We associate that with rheumatoid arthritis. The CSP is negative, so she does not have rheumatoid arthritis by that combination. Negative ANA, negative double-strand DNA, negative ENA is fairly interesting. That does help reduce our concern for various autoimmune conditions, especially, like I said, lupus. By definition, you have to have a positive ANA to have lupus, so that's not what's going on. But other things, the ANCA vasculitis, you can have a normal ANA with that. And I see that there's no ANCA. I guess the ANCA is currently cooking. A nice long bake.
And if you care, there was a CRP done, and I can't explain it. It was normal.
Okay. There are certain conditions. I wish I could curbside my wife like I usually do on service because there are certain conditions that lead to individual elevations of ESR versus CRP as opposed to both. I'm sorry, I can't tell you what those are, but there are certain things. So something I'll have to look up and get back to you on afterwards. So I guess while we're waiting for stuff to return, I mean, at this point, I guess the only thing left is additional infectious evaluation, but
there are some other things growing or trying to grow. I'm so sorry.
Rocky Mountain. Yeah.
All of these did come back quite quickly.
So lower tick. So Rocky Mountain spotted fever, no ehrlichia anaplasmosis, no Francisella. Right now, I mean, we're doing all the appropriate workup that we're supposed to be doing to look for any kind of infection, to look for any autoimmune disease. It can make an argument to get a CT of the abdomen pelvis to just fully image her to see if there's anything brewing into her abdomen that could be causing these issues. Maybe that's where this, we see small degree of lymphadenopathy around the trachea and the hilum. But is there something kind of more in the abdomen that's more pronounced, and that could be a target to go for further evaluation?
She did have that, and I can tell you, no, there was nothing there. I didn't bother to show the images. For the cardiologists in the room, I believe you said you wanted an echo.
Yeah.
I mean, this is Lawrence Hospital, So just to start off with, here's her EKG, and as you can see, it's not altogether normal. But of course, nobody was thinking that she had ischemic chest pain. But did we get troponins? Of course we did. And they were basically undetectable.
Well, that's good.
So this did bring up some concerns. What's that? Let's just get an echo. That is totally how it happened. And look at that.
Okay.
I will, again, for sake of time, tell you that everyone was running around with their arms, Muppety arms like this. Oh my God, what is gonna do? Cardiology consult, they're like, just recheck it. We rechecked it and it was small to moderate.
Fixed.
All attention went away from the heart and never returned there.
Um,
How about this?
yeah.
How about I tell you a little bit about what happened?
Okay.
So she was initially treated for histoplasmosis. It was an assumption, and I think a very reasonable one, that this patient had histoplasmosis until proven otherwise. And it was pointed out to us about 100 times that a negative urine antigen never meant that somebody could not have histoplasmosis. She was treated appropriately. Malik and I wrung our hands for days. She's not getting better. She's not getting better. Not a lick better. In fact, she was getting a little worse. On the 6th day of the hospitalization, she suddenly dropped her hemoglobin to 6.7. We transfused her and we were really worried. And that's when we really started pushing infectious diseases and others saying, this is not right. If this is histoplasmosis, how do we explain that? On the 8th day of admission, more microscopic hematuria was noted. However, it never progressed. Her creatinine stayed exactly the same. She had a renal ultrasound, for what that's worth, that was totally negative, and it never signified anything. On the 9th day, she desaturated into the 70s. Something is clearly the matter. She ended up producing much more dark bloody sputum, went to the ICU, got intubated. And on that very next day, her hemoglobin fell again to 5.5, and a BAL was performed by Millie, actually.
Good job, doctor. What did Dr. Horn see?
All right. What she saw was blood.
Yikes. So,
And that's what I got for you. Now, remember, of course, this would not have come instantaneously, but everything was negative.
yeah, so looking at the blood, I presume that's bottle like first, second, third wash in that order. And you can see how the blood gets, it gets more progressively darker, progressively bloodier. That's consistent with diffuse alveolar hemorrhage.
That's correct. That's what she was diagnosed with.
So she had diffuse alveolar hemorrhage. The question is now why? So there's really two big buckets for that. It's either autoimmune or non-autoimmune, which you could literally describe everything by that. But it's so immune causes.
It's
So
like saying things are genetic.
yeah, exactly. So the autoimmune causes are really more for the vasculitis. So we're waiting on those ANCAs to come back.
We're still waiting.
Still waiting. It's a long time to get those P ANCAs and C ANCAs.
Would somebody like a little more imaging?
I would like some more imaging.
Because she's tanking?
Absolutely. Let's see what a chest X-ray looks like, and they may have gone to. That's not good.
In addition to those dense consolidation, we have this more diffuse ground glass throughout all lobes of the lung, which would be consistent with diffuse alveolar hemorrhage given her.
Yeah, her lungs are not happy. They be bleeding and not well. So
they're jacked up.
Yeah, to put it bluntly. So I mean, there's no other, like we knew that from the BAL. So no new pathology. You can actually see that. Is that actually a bit of a pericardial effusion up there too?
Yes.
Around the heart. So consistent.
But not a lot.
Not a lot.
So I told you that I lied to you, didn't I?
Yeah.
I did lie.
What did you lie about?
So by this time, it was on the 11th of July that some slides from outside hospital finally arrived. We had been waiting for 10 days for those slides to arrive.
Mhm.
Where did they come from? Well, somebody said, hey, this doesn't look like pneumonia. Let's do a biopsy of the right upper lobe. And
Yes.
that's what was done.
It was her twin.
It was her twin. There was hair, teeth, and a spinal column in it. So we finally got those, and I have the reading for you. So I am going to do this. I've practiced it.
Great.
Guilherme Gomes Almeida from pathology. I hope I did it right. Portuguese, the internet tells me.
For those of you who don't know, we were quoting My Big Fat Greek Wedding, which is an excellent, excellent movie, especially from people who have cultures from the Mediterranean, like my own family. So go ahead.
So thanks for the kind introduction. My name is Guilherme. I'm from Brazil, so it's Portuguese. So I have some of the pathology images. Those are scanned slides from a consult because the slides were from the outside institution. This is a cytology slide, and here is basically the smear. So they did a endobronchial brush and smear on a slide. And here on the right side, we can see benign bronchial cells with the cilia. And on the left side, we can see a mixture of inflammatory cells. We have some neutrophils, some macrophages with pigment, and we also have lymphocytes, so a mixed inflammatory infiltrate. Here is the H&E slide for the biopsy, and this is from the trachea. And we have our traditional shades of pink and purple from pathology. And we can see that, I think you can appreciate, it doesn't look like your normal histology from the trachea. It's really busy with a lot of inflammatory cells. We can start appreciating already here hints of giant cells and basically all these lymphocytes. Here on higher power, we can see there is necrosis. All this pink, dense eosinophilic material is necrotic. We can see that the histiocytes are clustering together forming giant cells. And we have a mixture of acute and chronic inflammation consistent with a necrotizing granulomatous inflammation. This is another field. We can see again the giant cells and the abundant mixed inflammation. And this is the core biopsy from the left upper lung lobe. And it's a similar picture. We can see here on a low magnification, geographic areas of necrosis, all this inflammation.
Shouldn't there be holes where the alveoli are?
What's that?
Shouldn't there be holes where the alveoli are?
Yeah, so that's correct. So it doesn't look like normal lung at all, right? It's just sheets of inflammation. And again, the giant cells, some foamy histiocytes, all this necrosis. Here again, nice giant cell, some foamy histiocytes, necrotic debris, and mixed inflammation. And I put this picture just to show, we didn't have a lot of vessels in the biopsy, but right in the bottom here, this is a vascular wall. It's probably a vein because there's not a lot of muscle, but it looks pretty clean. And here you also have another vessel, and around it, all this inflammation. And you have some smooth, this is smooth muscle, probably like from a bronchial wall.
Look at the right there, that's loaded.
This is just to show, here is the patient sample on the left, and this is the positive control. So that's how fungi should look like if it's positive. So this is a negative stain. When I was a first year resident, I was like, oh, fungus. But no, this is just elastic. Yeah, this is just.
Right there.
Yeah, I was like, oh yeah, I'm so smart. This aspergillus, like acute angle. No, this is just elastic fibers.
This is why we have positive controls, guys.
Yeah, and so this is how it should look like. And this is the AFB. And again, this is the patient sample, which is negative. And this is how it should look like if it's positive. So negative for the infectious workup. And CMV immunostain was also performed. And the positive control, they used the brown chromogen and is a nuclear state. And we can see it's also negative. So basically, it was a necrotizing granulomatous inflammation. The two things we need to exclude the infection and also, I would say, autoimmune. Too.
Yeah, I think at this point, I mean, I don't know if there's other infectious workup we could possibly do to clarify it at this point, but I think it's most likely not infectious unless it's, I don't know, there's one of those extremely weird things. It does lower my concern for that. I mean, autoimmune is still the bigger cause. Is this the giant cells? Like this isn't, you mentioned that the larger vessels are relatively normal, which was my concern for a large vessel vasculitis, like giant cell arteritis. This is not a presentation of giant cell. She's also not the demographic. That's like 50s and 60s. I guess at this point, it's also time-wise, what's the ANCA? I think that's the one thing that's
Right.
outstanding.
That is the one thing that is outstanding on purpose, right? You know, sometimes we have to do these things to make the show good. The question I have,
Mhm.
if you didn't have visual appearance, but somebody gave you a reading that simply said granulomatous inflammation, could it be histoplasmosis? Remember, there's no necrotizing vasculitis seen.
I mean, with all those, so just the read, excluding all the other
Yes.
things we've done. I am not fully qualified to answer that question.
I didn't feel fully qualified either. The answer from infectious diseases was absolutely this could still be histoplasmosis.
Okay, interesting.
And that is why she was treated the way she was treated. You know, at some point, these labs have to come back, don't they? And they did.
Impressive. So ANCA is 1 to 80, PR3 is very positive, MPO is negative, and the GBM is, of course, another consideration well. So interpretation of this would be consistent with with GPA, granulomatosis with polyangiitis, and that kind of goes in line. You know, now that we have this information, it goes in line with some of the other pieces of the history as well. So it's one of the one of the vasculitis affected the kidneys, so that's why we have a little bit of the hematuria, microscopic hematuria. The history of the sinusitis and the allergic rhinitis now kind of comes into play a bit more, all linking up with the sinusitis, the lung disease, and the kidney disease as well. The other ANCA-associated vasculitis, you have EGPA and microscopic polyangiitis. Microscopic polyangiitis usually just has lung and kidneys without the
That's right.
sinuses and tends to be more MPO positive. And then EGPA, you would have the eosinophilia, and usually the history, big thing of history is they have extremely hard to control asthma. Like 90% of patients have hard to control asthma. So it seems like GPA complicated by the diffuse alveolar hemorrhage. There's also another important point that she got, thankfully, all that tuberculosis testing, because she's probably going to get some heavy duty.
That is
depression.
correct.
If she gets any B-cell depleting therapies, make sure you get a T-spot to look for tuberculosis as well as a Hep B. Because if you don't do that and they have it, you will do severe damage to them.
Did she get another T-spot? Of course she did.
Yeah.
And it was negative. To lay the sinuses to rest, out of desperation, ENT was called to do a rhinoscopy. They did, and they said, we ain't got nothing to biopsy. Bye-bye. We'll sign off. There was nothing there.
Okay.
So whatever this is really localized. So what are you going to give this as a diagnosis?
So I think it's granulomatosis with polyangiitis complicated by DAH.
That is exactly right. And based on that, obviously her therapy was dramatically changed. I think in looking back at this case, I think we may have stayed with the initial treatment a little too long. But knowing everything that we know, there were so many things going on. Sticking to your guns diagnostically does make some sense. So her antifungal treatment was stopped. She was put on high-dose steroids, and she then transitioned to prednisone. She got a dose of rituximab. She consistently, steadily improved and was discharged. She's actively followed. Bjorn follows her. She's had some issues, scarring in her lungs, some issues with bronchiectasis as well, which is why the first bronchoscopy was so hard.
Yeah.
Our bronchoscopist didn't have as much issue, but that's why it was so hard. But ultimately, she's doing darn well for somebody who almost died.
Yeah. You can see kind of this really speaks to how dangerous these diseases are. And again, the utility, mentioned all the histo stuff, my initial approach highlighting kind of malignancy and autoimmune disease and making sure we do that appropriate rule out for all the infection. came in to play here. So this is also why we have a healthy respect for autoimmune disease and why being married to a rheumatologist is very useful.
That's
Always
right.
have these in mind.
And the histoplasma, I wrote these things down and I'm like, well, it isn't always obvious, right? We live in Missouri, so we do see it.
Yeah.
And to us, it feels kind of routine and kind of obvious, but the testing is not 100%. And by gosh, histoplasmosis is way more common
Oh, yeah.
than ANCA-associated vasculitis, particularly GPA, is much less common than microscopic polyangiitis. So there you go. Thank you so much, Dr. Daniel. We appreciate you.
Thank you all for sticking. We're probably just going over. We just had so much fun talking.